Okay, so at the moment I have negotiated access for IBDoc kits for all patients on biologic therapy, but I would like to roll that out, and I do strongly believe it should be a standard of care that all patients have access to IBDoc, simply because from a patient perspective it facilitates things like virtual clinics, self-management, which is really important from a patient perspective, and the young cohort of patients that we have, generally kind of 18 to 50, it really facilitates their working lives. It also frees up our clinic time. So the processes at the moment is I do have access from a pharma company perspective for all of our patients for IBDoc, but I would like to roll that out for all patients. So once the patients are included, so for some biologics, subcut biologics, it's part of the care program. So the kits are given directly by the care company that provide it. So they don't come via us. So we introduce the idea of IBDoc to patients. We take their email address, we talk them through it, and most people are really, really happy to be involved. So we log them on the system, and they get the kits from there, and they watch the YouTube video, which is very, very easy to use, and they use them from there. So all of them at the moment have access to 4 kits a year. And I think that they need that many from the perspective of they do one when they start the treatment, they do one 12 weeks later to ensure that the biologic treatment is working. From there we give them a spare kit that if they're just beginning to have symptoms and they're wondering if it's a flare, or it may not be, it may just be something they've eaten, that they can check themselves. And the other one is for the end of the year. So that's the 4 kits a year. Mm-hmm. So, I mean, all of the normal ones don't raise any flags. If they have upcoming clinic appointments, we would cancel those clinic appointments because we can say with total confidence that they don't have active disease and that their treatment algorithms are working. For patients that obviously have moderate disease, we would fast those for a fast-track clinic appointment before the disease progresses any further, and make adequate interventions from there. For patients who have high IBDoc results, we would most often book an urgent colonoscopy to fully assess what's happening and what treatment needs to change. Well, we would look at if their suitability for virtual clinics, and then we have a certain percentage of patients that have been having normal calprotectin results for a while, and we would put those into virtual clinics. So I run virtual clinics, and they would be people that are well, having normal results. I would facilitate a virtual clinic on an annual basis for those patients. In the meantime, they would self-monitor using IBDoc and getting their bloods done. So we strongly advocate self-management. And again, because they're young patients, we don't want people coming into clinics. So if patients have symptoms, what we say to them is check using IBDoc. It's outside of colonoscopy. It's the gold standard fetal calprotectin to see if there's disease activity or not. We do have a telephone helpline, yeah, and they would call, but that would be our first thing to say to them. Without a calprotectin result, we have no idea what's happening. So that's the first thing to do. I suppose from our perspective, it's very helpful because you can very clearly and very quickly decide, yes, this is a flare and we need to fast track and do something from that perspective, or this is not IBD related. And even from a patient's perspective, it's very important that they know the difference, because sometimes we can have IBS overlap, and sometimes we do have patients that have a symptom burden but no active disease. So that's a really important differentiation to make. So their trust comes from our trust in it. So we can say definitively, if the IBDoc result is normal, you do not have inflammation. And that has borne out, as we can see from the poster, with 20% who had high disease. They all correlated with disease activity on endoscopy. Equally, from a normal perspective, we haven't seen people having active disease, because sometimes with a symptom burden, despite having normal calprotectins, we do have to go in and do colonoscopies on occasion, and all of those prove to be normal. So that's very reassuring from our perspective clinically, but also from a patient perspective. So at the clinic, of the moderate people, probably 50% of those would end up having a colonoscopy depending on their symptoms. And the others, we may start steroids or add in another therapy in combination with the biologics. We would change something and see how that goes, and then they would recheck their IBDoc in a couple of weeks after that to make sure that that's working. I would say the vast majority are having a flare. We find that IBDoc is very predictive of full-on flares. So if they're moderate, that's the time to, and that's why we fast track them, that's the time to add in a treatment, or that's the time to make a clinical decision before they get to high. So it is very predictive of having a high level within a couple of weeks. We believe in early intervention just from the perspective of if we can get in early with a treatment, it doesn't allow the disease to progress, and therefore you have better mucosal healing over time. Exactly, so they would be fast-tracked automatically within a week. No, because I don't feel we have to, because that's what the job of IBDoc is. These patients can self-check at home if they're having some symptoms, or just to make sure every couple of months that they're doing okay. If there's no flag on that and it's a normal result, there's no reason to see them more often. Yeah, we have extremely positive feedback from patients. Again, because the cohort are young, most of them have compatible phones. It's very easy for them to use. It is literally watching a YouTube video and doing it themselves. So we only have positive feedback from them. Absolutely, and that's why IBDoc ties into tight control, as we term it. It really is about intervening at a stage that we know there's inflammation starting. And we see all of the time that people that have a low value of moderate, that if we intervene, then certainly we're saving them in the long term from having a full flare. So yeah, tight control certainly feeds into better clinical outcomes for patients. So what happens is I have a patient pack that I post to them, and it's a questionnaire and of self-assessment of symptoms, and also we would ask them to do IBDoc and get their bloods done with their GP. And so by the time we make the call, we would let them know the time and the date that we would call them, and then we would make the phone call. They will have their calprotectin result and their blood results, so that's the clinical evidence that we need to make decisions. We would also go through their symptom burden and their questionnaire and make decisions from there. So the cost savings, are significant from the patients that we can move to virtual clinics, and I have done some costing around that, but it saves on average in terms of euros, 128 euros per patient visit. And that's just a clinic visit, that's not including bloods and all of the other things. So from that perspective, it is a huge cost saving. It does also free up consultant time and IBD nurse time in terms of I suppose time for patients that have active disease and that we know have active disease. Though virtual clinics is our biggest one in terms of cost savings, but also it's cost saving from a colonoscopy point of view. So if we know that the results are normal, we don't have to go and do a colonoscopy. That has saved significant money to the hospital. We have over 3,000 patients in our centre. We need to be able to run it very efficiently and cost effectively, and that comes from the fact that we can promote self-management. The biggest advantage of self-management and being able to facilitate it is IBDoc.